Let's get started. So thank you everybody for coming to join us for this great talk. It's my pleasure to introduce Nino Paranashvili. Sorry. Nino obtained her physician assistant degree from the University of Toronto in 2018 and has been working in Halton and Mississauga rapid access addiction medicine clinics since then. Prior to her PA training, Nino graduated from medical school in Eastern Europe and has served in numerous areas of medicine in Canada. While working in pain management, she developed a special interest in addiction medicine. Nino additionally holds a part-time position in fertility medicine. She's actively involved in teaching and has a major interest in research and medical outreach programs for those in need. So welcome, Nino.
Thank you. Thank you so much for introduction again, and thank you for joining me today. And as it was mentioned, I graduated PA school at in 2018, and I have been practicing addiction medicine since then. I recently changed part-time, fairly recently, a year and a half, to fertility medicine, but part-time because I do love my addiction medicine field. It has a special place in my heart, and I'm very passionate about it. And so I can't give it up. So I do have a special love for this field and enjoy practicing really every day. So thank you for joining and sharing the interest with me. So I'll go through some information that I wanted to share, some cases. Hopefully we can have a bit of a discussion at the end as well. So what I was hoping to cover today, do we have a tech person? It might need to be reset. But either way, what I wanted to cover today is, the model of RAM clinic, some of the treatment options available for treatment of alcohol use disorder, because it is quite prevalent, it is underdiagnosed, and we do have quite effective treatment options available for alcohol use disorder. And so I do want to move my slides if we can. Oh, there it is. I think we're good. And I also... well, thank you for fixing that. Yes, so moving on. So I did want to go over RAM model. I'm not sure how many of you are familiar, but it's a wonderful model that allows people to have same-day appointments with or without referrals. And it's a game changer, really. Medify is the organization that really contributed a lot and helped a lot of RAM clinics to be developed. And currently we have over 70 RAM clinics in Ontario. The purpose of a RAM clinic is really to be a low barrier access, right? So if you want, you can just make a quick referral. If not, you can just tell a patient, just dial the phone, call them. It should be low barrier, meaning that we see people who have no health cards even. So it's that low. So parking is available, it's OHIP covered. There is very little that should prevent, other than, if patient is just not willing to. Now, a lot of people associate RAM clinics with methadone clinics, which is not necessarily true. We do treat all substance use disorders, including opioid use disorder, stimulants, benzos, cannabis, really pretty much everything. Oh my, I wonder if I'm not pointing properly. No, do we need to reset it? Yeah, this is just nothing to disclose. I wanted to share with you this Medify website, because this is where you can find really available clinics. So it's very easy. If you go to their website, you see RAM locations, you enter the city, and if you do have time, if you let the patient know where they can go, that would be wonderful. If not, you can at least indicate the website. And there's so many locations, and right now a lot of them do provide care over the phone, so it's an easy access care. And it's very important specifically for any kind of substance use disorder patients, including alcohol, because it's important while they're at that stage where they want to pick up and go or make a change. It's important to use that opportunity, right? Few historical facts that I wanted to share. Just chemical analysis of jars 7,000 BC confirmed that fermented drinks made of grape, berries, honey, rice were produced in China. So meaning that it's been some time around. And two milestones that I wanted to share. 1784, alcohol use disorder was identified as a disease, if you will, and then foundation of AA, 1935, which is a big milestone because it does allow a lot of our patients to achieve their goal easier, maintain their progress easier. And there's actually some evidence that shows that people who do have sponsor, they just do better recovery-wise. Now, this is some of the statistics to kind of, how acute this is. So we do underdiagnose a substance use disorder. It's important to identify because we do have very effective treatment options. And what I usually say, substance use disorder is a disease of family and society, right? Because it greatly affects their families, loved ones, children, and society, healthcare system, right? And society overall. So it is important to identify and refer. So as you can see, 10 to 20% of patients, AUD occurs in 10 to 20% of patients that present to primary care and hospitals. And GP will daily see about 4 patients with some kind of problematic substance use, let's say. So the other thing is alcohol use disorder is directly associated with some of the negative health outcomes, right? Including hypertension, liver disease, memory loss, obesity, many other ones. There's actually dose dependent, if you will, not necessarily dose, but if person consumes 4 or more drinks per day, they're 2 to 3 times higher fold at risk of fatal car accidents, liver disease, coronary artery disease, and so forth. Now, AUD decreases with age. Rates are highest among 18 to 30, so maybe pay a little bit of a closer attention to that population. Rate of AUD in men is twice of that of among women, but quite prevalent in women as well, right? And then some of the interesting thing that substance use disorder, including alcohol, has high genetic predisposition, right? So of course, like other factors matters, like biological factors, exposure to alcohol or substance, availability of substance, right? But it has strong genetic predisposition, and you can see in females it's up to 70%, which means that they are born with brain vulnerability to develop habits sooner, right? To anything really that spikes dopamine. And so in some cases it's alcohol, some cases it's opioid. I'll get into it a little bit later. Maybe we can change a slide. Thank you. This is just a brief slide to remind you guidelines, drinking guidelines. And then the interesting thing is that in US and Canada, we have somewhat similar guidelines, but interesting fact is that recommendations are 50% lower in Great Britain, but you can see that there's 50% higher, which is quite significant in Italy, Spain, and Portugal, right? Yeah, so you're not considered alcoholic there when you are here, right? And so government standard drinks, just for your information, now, blood alcohol levels, so this is the legal, it has to be less than 0.08%, right? And it typically occurs after 2 hours after drinking 4 drinks in women, 5 in men. And so because average metabolic rate of alcohol is about 7 grams per hour, it translates to 1 drink per hour, right? So basically, if you drink 1 drink in an hour, you'll have BAC less than 0.08, just in case. All right. Now, very basic metabolic pathway. So we have ethanol, and then we have alcohol dehydrogenase, which converts it to acetate. And then we have aldehyde dehydrogenase that converts to acetate. And acetate is a final metabolite that we excrete without any issues, right? This is anatomy, if you will, of substance use disorder. And I say substance use disorder because substance use disorder is an umbrella term, right? And substances are really a manifestation of it, which means that it's the way brain reward pathway reacts to substances. So it's the vulnerability to develop habit. And so, sometimes when people recover from alcohol, that addiction pathway wants to survive, right? And it's a strong part of the brain, as you can see, and it tugs and pulls to fit in anything. And the issue is sometimes it substitutes, right? It could be cannabis, it could be cocaine, it could be anything that spikes that dopamine, it could be gambling, video games, right? And so the areas that are involved are ventral tegmental area, nucleus accumbens, and prefrontal cortex. And this is to say that it's extremely powerful part of the brain. It's the same part that is responsible for high executive functioning, right? Like the decision-making, habit forming. And so like anything else, it wants to survive, right? And it will tug and pull. And people will say, well, I did so well, right? Well, I can't sleep without it. Well, I can't work without it. And it's very important to direct the patient saying that, it's addiction part of you talking, right? Like, it harms your family, your finances, your health, but it's that addiction pathway that is very strong and it certainly wants to survive. And historically, we also thought that, it's personal weakness, it's a moral failure, or even a poor choice to be dependent on some kind of substance, right? And we very well know, and it's important to let the patient know as well, so they don't feel judged. They feel that it's just another condition that they have that they require help with. It's similar, like hypoxia modifies some of the myocytes, right? And so it's similar. There is a substance and there is modification of neuronal circuitry, if you will, as well as neurotransmitters are affected, right? So main neurotransmitter, of course, is dopamine, but GABA glutamate is involved, serotonin is involved, acetylcholine is involved as well, right? And that's important to know because we're going to get into pharmacology a little bit later. Yeah, I like this picture because when we used to be fully in person, I don't know, 3 years ago, pre-COVID era. So what it shows, this particular scan is Dr. Valkovsky. She's big in addiction. She's a wonderful researcher. So this is specifically for methamphetamine use disorder patient. But what it shows is that, so this is like to the right is a healthy control. And you see those little red dots on the PET scan. Those are normal dopamine spikes that we would expect. When person is using methamphetamine, it's very hard to get that dopamine spike. So from normal pleasures that we would get, right? Food or really any pleasurable activity, right? We get the dopamine spike. It doesn't happen in methamphetamine use disorder patients or stimulant use disorder patient, really. And so what I used to show, because it's a nice positive feedback to a patient, right? So it means that there is a light at the end of the tunnel. So if you abstain, in this case, 14 months, which is long, and I usually tell patients, the change will not happen over a week, over a month. It might take a while because it's multifactorial disease, and there's a lot of things that needs to be adjusted to get you where you want to be, I would say, right? And so, but there is a light at the end of the tunnel, because at the end of the day, you see that after abstinence, certain amount of time, that it goes back to normal dopamine spike, basically. I'm not going to go over all of this, but there is 11 criteria to diagnose any substance use disorder. You could put alcohol, you could do cocaine, you could do any substance, really. And you can see if you say yes to 2, you qualify for mild substance use disorder, whatever substance you put, right? I'm not going to go over all of the criteria, but I do want to emphasize the 4 C's, all right? And really the biggest C of addiction we call is a loss of control, right? So they will say, I pour the glass, but I can't stop there. Like once I pour, it just goes on and on and on, right? So treatment options, there is different modality, right? And so in our clinic, we mainly focus, of course, there's brief motivational interviews, and of course there is counseling involved, but we mainly focus on pharmacological treatment of substance use disorder, in this case, alcohol use disorder. But there are different modalities. And for some people, one thing works better than the other one, right? So as I tell patients that there are 3 triggers, right? People, things, and places. And if they're not able to modify all of that, and they've been trying for a year or 2, and with pharmacological, all the combinations were tried, and we're still not where they want to be, in patient residential treatment, something to consider, right? Because it's a very structured environment. And so when they remove you from all the triggers and there is a structured environment, it kind of gives you a good start. And then we will kind of take over again. Community withdrawal or detox centers, right? Where we go, where they go, for example, for 5 days, and there are basically detoxing and treated symptomatically with benzodiazepines or whatever the symptoms that they have when they are in withdrawal. Mutual support groups, counseling. I do want to emphasize that it's really much evidence-based, that we say that when we combine pharmacological treatment option with counseling, addiction counseling specifically, people do achieve their goal and maintain their progress way better than one or another. Now, I bolded 3 medications that are approved for treatment of alcohol use disorder. The other ones are not necessarily approved, but we do use some of them quite widely and successfully. Some we have tried in very, seldom occasion, and sometimes we use a combination, of course. Now, I'm going to go over 3 or 4 medications because, they're fairly easy to prescribe. Very little monitoring is required. And then maybe we'll go through cases. And I have done alcohol use disorder presentation with Dr. Holub, who is my supervising physician in the past. And I think I've done it a couple times. This time I shortened it because from feedback, it seemed rushed and I didn't want it to be rushed. So I took out some of the cases, but hopefully we can go through at least a couple. But I'll start with disulfiram. And so I usually start with this medication. I'll say, well, have you heard about it? Because historically, this has been longest on the market, right? Since 1951, this is available. And this is the medication that makes people violently sick when they drink on it. I don't necessarily like it's never my first first choice, if you will, because it's almost like a safety blanket, right? So if you take medication, if you drink on it, it makes you violently sick, but it doesn't act on any receptors. It doesn't alleviate any cravings, or it really doesn't help too much with desire to drink or pleasurable effects or anything, right? So it's as easy not to take and drink on it. Now, it does work quite effectively if the person comes and say, that's it, I want to stop immediately, give me something that makes me sick. And certainly it does work in a few, selected patient population, especially if they have what we call contingency management, right? So if there is a spouse or a parent or somebody who gives that medication, so a patient will thank them for kind of participating, and the person thanks them for trying, and it builds the trust or rebuilds the trust and relationships. And so, because in addiction, a lot of it is lost, right? So this medication is good in some cases. And the way it works is, so we know the basic pathway, right? So ethanol to acetaldehyde, but what it does, it blocks alcohol dehydrogenase irreversibly. And so acetaldehyde can no longer be converted to acetate. And so acetaldehyde is a toxic metabolite which accumulates, right? And so it makes people violently sick. And I mean it, like they feel like dying, like throbbing, vomiting, nausea, headache, palpitations, right? Hot flashes. So it's very unpleasant. And this could happen in a very, very little doses of alcohol. Even we will say, be careful with your mouthwash or whatever alcohol contains. Typically, we will start with a small dose, 125 milligrams daily. Sometimes they will attempt to drink on it, so we will increase if that's what they wish. It is mainly excreted through saliva, so it does have some effects of like metallic taste, garlic smell. Yeah, I think that's all I wanted to cover about this medication. Now, one quick thing. It is important to note that it irreversibly blocks the enzyme, because some people will say, well, I'm not going to take it on Thursday and Friday because I'm going to drink on Saturday. But it's important to let them know that even if they do drink on Saturday, until the new enzyme is produced, this is irreversibly blocked. So they will still get sick. So it really requires pre-planning. And similar to starting, like you can't start, if somebody had alcohol this morning, you can't start it this evening because it will make them violently sick. And I included the handouts. I absolutely love them. Not only great resource for a patient because they will start Googling. And so, you know, everybody searches something very personal kind of stories, which almost dissuade them from making a right decision. And so this one has really pretty much, it's one pager, it's CAMH, it's evidence-based. It has like in percentages, the side effects, everything the patient knows, needs to know to make an informed decision, right? And even for myself, like I do find that it's a good cheat sheet, like whenever you need it or forget it or whatever the reason might be. Now, acamprosate, also wonderful medication, fairly new, available from 2004. This medication, so alcohol dysregulates neurotransmitters in the brain, right? And so what this medication is supposed to do, it's supposed to balance it out. And so when the person, it typically started when person is abstinent for about, let's say 4 or 5 days. And so this medication helps them maintain the abstinence. So they feel normal without reaching for alcohol. It doesn't have any addictive potential. Couple things. A lot of people do develop diarrhea on this medication, and so a little bit difficult to comply. Like we have people who weren't able to do their daily activities because of the side effects. And the other thing, it's taken 3 times a day, also a little bit an issue with compliance for some patients. Typically effective dose, and we start with this dose, 666 milligrams TID. But if there is any concerns like age, renal clearance, and so forth, then we start at the lower dose and then increase if all goes well. Also very effective medication, very expensive though, $300 a month-ish. So yeah, very expensive. So I included the same handout. And the cost matters, right? Because if somebody with low socioeconomic status does not have coverage, it's not something they take, it's not antibiotic that we take 7 days and that's okay, right? Like this is ongoing. So month after month they have to pay. So it really plays a role in the decision-making. So naltrexone, I'm sure most of you have heard because you know it's the best thing we have. It's first approved first-line treatment option. Works magic. I love naltrexone, and so again, this is the most effective medication we have, and in fact, it's over 80% of the time effective. We have people who drink like 3 bottles of wine per sitting. They will say, I had a glass and I put the rest out. I just didn't want anymore. So when it works magic. I love it because it's well tolerated. Rarely so somebody will have report some side effects. Up to 12% may say, you know, I have nausea, indigestion, maybe mild headache. Sometimes occasionally there is some rare side effects, but overall very well tolerated, benign medication, taken once a day, wonderful before bed. Really, we say with the dinner, so easy not to forget. The effective dose is 50 milligrams, but sometimes we do increase it to 100. The quick thing is that it does require hepatic monitoring because rare but reported side effect is a liver toxicity. Now, what I usually say to patients, you know, it's much less harmful than alcohol is. So maybe it's worth trying anyways. Typically, they will say, do not start it if the LFTs like AST, ALT, or GGT, if they're 3 to 4 times of upper normal limit. We typically are quite okay starting like maybe 4 times, even a little bit more. We will just repeat the blood work a bit sooner just to make sure it's not going any higher. But and so the way it works, it actually blocks brain opioid receptors, which feed into that dopamine reward pathway, right? And it significantly reduces cravings and pleasurable effects of alcohol. And because the way it works is it blocks brain opioid receptors, we do warn the patients, learned it hard way, but do not start this medication if somebody is on opioids, because this just kicks out the opioids from their receptors and puts them in withdrawal that can't be undone really until it just clears. And so we do warn them that if you ever need opioids for treatment of pain, do let your doctor know. They may use different analgesia. They may stop this medication. They may adjust the dose, but do let your doctor let them know. And this is just a handout. And then I didn't want to discuss any, not off-label treatment options, but I also love gabapentin because it really does the job. It is very effective. And I do find sometimes we start with gabapentin and retention rate is quite high because it helps people. It really does. Especially people who say not necessarily the craving is the major issue, but I just drink to function, right? I at this point, I don't get any sedation. I don't get any high out of it, if you will, but I just need to function. And so alcohol dysregulates GABA glutamate system, right? So those are neurotransmitters. We know that the GABA is the brake of the brain and glutamate is the happy neurotransmitter. And so when patient drinks on and off and on and off, and it's all over the place, right? All over the place, right? And so when they stop, and so there is a huge imbalance, and that imbalance causes what we call post-acute withdrawals, like irritability, anxiety, sleeping difficulties, nausea, whatever that might be for a person, tremors, right? And so what gabapentin does, it balances out those neurotransmitters and it works wonders for post-acute withdrawals. Having said that, this will not prevent any life-threatening seizures. It's not for acute management, but it does work. It is effective. The only side effect I'm usually worried about is drowsiness, because if they're working, if they're driving, typically we'll say, take your first dose at night. If you're drowsy, you'll sleep through it. And typically they don't sleep anyways without alcohol, so they would love to have some drowsiness if they do. An effective dose for alcohol use disorder is 600 TID. Now, we typically start with a lower dose to see if there is any side effects, and if not, we increase it to 600 milligrams TID. Again, this is off-label use. I'm sure you heard gabapentin is quite widely used for neuropathic pain, for actually off-label use for treatment of anxiety disorder as well. So, but we use it widely and successfully, and I love this medication. But one of my colleagues loves more. But yeah, so the case. So 51-year-old, are we on time-ish? So 51-year-old male was referred to our clinic. Those are all real cases for management of AUD by ADAPT counselor. And ADAPT is just a counseling, free addiction counseling agency, so community counseling agency. So with the help of addiction counseling last few months, he was actually able to reduce consumption daily from a baseline of around 20 standard drinks to 15, which quite significant reduction, right? For him, it's a significant reduction. So the patient goal is to be fully abstinent. It's very important to ask the patient what they want, right? Because you want to meet them where they want to be. If it's a harm reduction, yes, it is a dangerous goal. Yes, it's like playing with a fire, right? But it is important to meet them where they are. I do emphasize to them that ideally, it will be full abstinence, because that's the only way, because addiction isn't like a relapsing remitting condition, right? It's a chronic condition. We don't cure it, we manage it, we live with it, right? And so I tell them that, the only way that you gain control over it versus over addiction versus the other way is if you're fully abstinent, really, because the thing is, as I mentioned, the addiction part of the brain is so strong. If you feed into it like once a day or once a week, or on birthdays, you're still feeding into that pathway and you're keeping it alive. And because of the nature, it being relapsing remitting, more often than not, it does snap back to square one. So I let them know, but certainly we meet them where they want to be met. So he denies any other problematic substance use. And this is another important question, because as I mentioned, it's an umbrella term, right? And substances are manifestations. So it's important to screen if there's anything on board that should be taken care of as well. So any information that you would like to know about the patient? Maybe just shout out one or two answers. Any general things? Chronic disease, so past medical history, right? Correct. Anything else? Medications, yeah. Social history, very important. Family history, very important. Yeah, so all good points. So his past medical history, so he has, it's significant for high blood pressure, pancreatitis, diabetes, No liver disease and no seizures or DTs. We usually screen because, you know, if you had it once, you're at a high risk to having it like next time as well. Past psychiatric history. With substance use disorders, it's not uncommon to have comorbidity, like psychiatric comorbidity, so we do screen for that as well. So he did have quite severe depression and anxiety. This person wasn't able to come out of home. He severe social anxiety, PTSD, and denied suicide attempts. His medications were metformin, bisoprolol, trazodone, and citalopram. And I forgot to mention he was on benzodiazepines at that time as well. Now, this is his urine test. So those are the substances that we test in our clinic for. It varies from clinic to clinic. It also varies in our clinic based on is it opioid use disorder patient versus alcohol use disorder patient? But as you can see, some of the substances that he was screened of, ETG is ethyl glucuronide, which stays positive in urine 3 to 4 days. So it's a great screening tool for us to see when was last consumption. This is just how it looks. Well, at least at that time, how it looked. It changes again with time and with what we are looking for in this area. The substances are so evolving that we change it every so often. I looked up his blood work at that time on OLIS, and not quite sure I can share this, but there is no ID information. But his AST was 3.2 of an upper normal limit. ALT was normal. GGT is quite high. I personally never base my decision of treatment on GGT unless it's in the thousands. Then sure, I'm a little bit worried. But AST is more specific indicator for alcoholic liver damage, and again, it's between 3 and 4. So I wouldn't be worried starting any medication for this gentleman. Now, patient added that he struggles mainly with loss of control and craving. So one of the 2 C's, big C's of addiction, right? And so, given the patient has no contraindications, what would be the agents that you would want to consider in his place, in his case? You can just shout out, and there is no wrong answer because really you could try most of them. But what do you think would be the best one to start with, given the cravings? Yeah, right. Everybody agrees. It was started, and I included a little. So we have a clinicians chat where we kind of, if we need help or we ask each other things, or we share little things. And so I included little blurb that one of the clinicians shared, and this is what patient. It's a quoting patient. I think naltrexone is working. I'm gonna stop it. So it works when patient wants to stop it. Now, so we started him on naltrexone. We typically reassess in a week, like, is there any side effects? Is he tolerating it well? Is it beneficial, to see if we need to adjust anything, right? And so he reported further reduction, and this is significant. So now frequency has reduced, right? Instead of daily, it's 6 out of 7 days, and from 15 to 12 standard drinks. He did note cravings are diminished and pleasurable effects as well. So it did work well for him. What are some of the symptoms that you would want to assess this patient for? And again, there is not necessarily a wrong answer here. So what do you think the first thing in our settings, like outpatient management for alcohol withdrawal, what would you want to screen him for now when he has reduced the alcohol? Does he require further assessment, or? Right, he does. So, diabetes, sure, we could assess, but not necessarily relevant in this case too much. We definitely do need to assess him. Acute withdrawals, we always do have to rule out anything life-threatening, but it's not something that we are expert on, so we don't. If anybody requires acute withdrawal management, that they should be in emerge, not outpatient basis. So we typically assess for post-acute withdrawals, right? PAUSE, what we call. Now, as we know, alcohol withdrawal is a spectrum, right? And it's so variable. It varies. Some people will stop from 8 drinks to 0 and will feel nothing, and some will stop from 2 and will have the full spectrum of withdrawal. Some will start developing in 3 days and some the next day. And so It's a wide range of the symptoms, but they vary in severity, when they start. I'm kind of included acute alcohol withdrawal, but we're not experts. So this is just a general what I know from PA school maybe. But I know that thiamine is usually given to prevent Wernicke encephalopathy, and there's SIVA protocol, right? If they require benzodiazepines, if there is a severe enough withdrawal. We definitely do screen for DT because this could be life-threatening, right? For liability purposes and for safety purposes, we must screen for this one. But what we are experts on is post-acute withdrawals. So those are the same things, right? Irritability, anxiety, sleeping difficulties, but less acute, if you will. So and basically they happen because of the autonomic hyperactivity. Now, after a few appointments, the patient continued to reduce his alcohol, but asked him to assist with withdrawal symptoms. And so in his case, it was anxiety, irritability, insomnia, tremors, nausea, and fatigue. Nothing acute. There is no seizures, mild tremors, and he has pre-existing history of anxiety, which is a comorbidity that could direct you towards more or kind of lean you towards your decision towards one medication over the other. And so what do you think, and again, there could be a couple chosen from here, but which medication do you think is best to consider for POS in his specific case? GABA, right? Yeah, gabapentin. So this is again, a little blurb about gabapentin. Gabapentin is a miracle drug, but I don't want to take it. And the patient stopped it. So it works. And so people stop it because it works. Acamprosate could be chosen as well, but again, it's typically started when somebody is abstinent. But because he had comorbidity of anxiety, we started him on gabapentin at a lower dose. He tolerated it very well. It helped him greatly, but he continued to have some more symptoms. There was no side effect, so we increased it to a effective dose. And so this is his blood work a month later. We typically in our clinic will reassess liver function, in a month, 3 months, 6 months, and this varies depending on, what dose he's on and some other factors as well, past medical history and some other factors as well. But as you can see, his liver looked quite happy. Everything was within normal limits, and so he to date continues to follow us. His current regimen is he's gabapentin at a bit of a higher dose, but he is not sure so actively connected with ADOPT, but maybe somehow connected. And he's been maintaining abstinence since 2019. He discontinued taking benzodiazepines, and now he's at least more open going out. He had severe social anxiety disorder as well. So he's doing great. I'm really proud of this patient. Now, all of the following are used for treatment of alcohol use disorder, except anything jumps out that we don't use. Lamotrigine, right? So it's a mood stabilizer or seizure medication as well. I wanted to review, I think this is my last case, Mr. Britt, 45-year-old male who was referred to our clinic by Credit Valley Hospital emergency. So he had an MVA and driving under influence, very scary experience for a lot of patients. He consumed most of the day's vodka, 12 standard drinks, and last consumption was at the time of his DUI. He denies any medical history. This is fairly healthy, very functional younger gentleman. And his goal is to fully abstain and immediately, because it really greatly affected, like his wife had an ultimatum and his mom, and it really affected his life. So it was either stopping or changing quite a bit of things. I wanted to share this, like initially I was using this quite a lot, but then you kind of get used to the standard drinks. But this is a good resource. If you put ounces or mLs, and typically people will know what percentage they drink. If it's hard liquor, I usually put 40. If it's wine, typically 12, right? If it's beer, they usually know what they drink. So it calculates for you what is the standard drinks. And this is important because at the next follow-up, you want to know, well, are we making a progress, right? So all medications, wait, was there a question or no? All medication should be reviewed with the patient as an option, except, so anything that we shouldn't really touch. I mean, he's fairly healthy. He's already not consuming. So naltrexone, why not? Acamprosate, why not? Disulfiram, why not? Modafinil is not used for treatment of alcohol use disorder, right? So, yeah, he was not involved in any addiction counseling. Now, interesting to note that he reported very mild cravings. And if you see the frequency every couple of days, it didn't appear to be a challenge for him. And they last a very short duration of time. And it's important to let the patients know, right? So anytime cravings comes on, it will peak, but it'll go away, right? So it's something to keep in mind. And he denies any post-acute withdrawals as well. And so he was referred to ADOPT, which is again counseling agencies. And he asked, give me something that makes me sick because I can't drink. I can't afford drinking anymore because it's going to cost him family, right? And so we can go through this together. Given that no contraindications, what would you, like everything is correct except, so one is not correct. So medication works best when combined with counseling, right? We could start a trial of disulfiram. There is no contraindication really, and he wants something that makes you sick, so why not? Disulfiram is no longer available. Is that correct? Yeah, so the reason I put this question is because there is in primary care physicians, like few of them, there is a misconception that disulfiram is no longer produced, which is true in a way because the manufacturing companies do not produce it any longer, but compounded pharmacies will make it for you. So all you have to do is just ask the compounding pharmacy to make it. And so, and then the other one is we went over. So he has been actively involved with addiction. He has been taking disulfiram and he has been successfully maintaining, again, this is over 3 years now, doing wonderful. He got his license back. His family is all good. It was, in his case, it was mom who kept administering the disulfiram. He did use contingency management in the beginning. Next slide. Sorry, I don't know. It's not. Oh, there it is. So this is my team, and Lana is here, one of my teammates. And the reason there's a couple of reasons I wanted to include this. So that was our team before COVID. So very recent, like maybe 3 years ago, right? And so this is not even a full team that I included. We have more physicians, we have more PAs, more nurses, more admin staff. And this is to show that we grew like really fast. And this is to meet the demand. It's been crazy. We went through seeing 5 patients a week to maybe 150 patients a day. So demand is huge. And I also love these people because the field is not easy, right? It gets challenging. It really does. And these are the people that really make it all worth it at the end. So I just wanted to share my team. Well, thank you very much for listening. Hopefully it wasn't too boring. Do we have time for questions? Anybody has any questions? So we are in the process of hiring one new graduate PA, and hopefully he's going to accept the offer. But we have 3 currently. We had 4, but one had to go on maternity leave a little bit sooner than we expected. So 4, this would be 5th PA that we are currently hiring. We have 3 or 4 physicians. It's hard to tell. We're growing so fast. We're constantly adding people on. So. And we have now 2 nurses. One is on mat leave, and in addition to that, 2 nurses. So yeah, we've grown quite a bit. Yes. Yeah. So very good question. It really depends how well patient is doing. So if it's what we call stabilization phase, if you will, if the patient is not at the goal they want to be, right? So we call them every week. You know, do you have addiction counseling on board? Are you taking your vitamins? Are you taking your medications? And we always check, like, is there a room to adjust? Is there room to improve? Like, what can we do to get you to your goal? So it's weekly appointments. If there is more stability noted, typically if patient is abstinent for, you know, let's say a few weeks, couple weeks, then we'll say every 2 weeks, and then we can move up to a month. But it also depends if they are comfortable, if they have any kind of psychosocial support in addition to us. Depends on a specific case, but typically it's once a week, and then we move them to 2 weeks, 3 weeks, and a month. Also patient preference. If they want to come in, some people like to leave urine sample, and it could be because of legal reasons, because they are going to require it later because of, for family doctor or for CAS, I don't know, for whatever reason it might be. For some people, it's a positive feedback for themselves, right? Like they will say, well, they love to see it's negative. It just reminds them that they made such a tremendous progress, right? Because it's not easy. It's not easy. Like, so yeah. Yeah. Did that answer your question? Yeah. Any other questions? Yeah.
For a patient that was started on Cantrell during an accident period,
yeah.
They started drinking and you started leaving them on the medication?
Yeah, we would continue Cantrell because it still balances out the GABA glutamate system, right? So we will leave them on Cantrell, but we may, depends what was relapse. Was it trigger induced? Was it specific? Maybe it was a party. Maybe there was something that happened, right? And it triggered the person. So then depends what was the trigger. If it's something we can quickly fix, we just don't make any pharmacological changes. But if he says, well, you know what, it's been doing a good job, but now my cravings are higher and this is this and this is that, then depends what happened. We may add naltrexone if cravings are an issue. We sometimes even combine gabapentin and acamprosate as well, depends. But yeah, we would leave them. It's not contraindication if somebody relapsed to completely drop them from acamprosate. It won't interfere with alcohol. It won't make them sick. It won't, yeah. I think it did play. I think it really did play a big role because again, it's such a multifactorial condition, right? A lot of things matter, a lot of triggers matter, and so for some people this was the push, and I think it did play. But we certainly grew quite a bit during COVID. Yes. So yeah, very good question. So we have three psychiatrists and one family doctor. Sometimes we get local family doctors as well, like emergency doctors, but all of them have some knowledge or training in addiction. And especially our clinic provides also, stimulant use disorder, opioid use disorder, so they must have some kind of baseline knowledge. So all of them are quite well trained, but 3 of them are psychiatrists. Yes. Yeah. Any other questions? Well, thanks again very much.